Hello, it's Dr. Jeffrey DeSarbo again. I'm the psychiatrist who specializes in eating disorders. If you haven't figured that out by now, I'm also the medical director at ED 180 in New York, where we treat a lot of eating disorder patients. And I work with a lot of therapists and nutritionists. And so I'm just kind of refreshing everybody's mind here as to who it is who's kind of giving you this information right now. Let's get started on the neuroscience of medications. There's two ways of looking at medications when we're working with eating disorders. Most people are thinking about, we're going to, prescribe certain pills, medications, maybe some over-the-counter stuff to help with things like moods, to help with things like sleep, to help with eating disorders. But it's really with an eating disorder, the primary medication is food. Even when we're talking, a person comes into my office with an eating disorder, mood is usually off, sleep's usually off. And a lot of times it's with kind of reestablishing a healthy approach with their food, their dietary intake, caloric requirements and things. That's the things that kind of work with to restore depressions, anxieties, sleep patterns, even with certain types of eating disorders. I remember when I was starting out, I learned quickly. Somebody called me and would say they're struggling with bulimia nervosa and binging and purging, and right on the phone I would say, "Are you also having troubles with sleep?" Yes. Absolutely. Are you also irritable all the time? Oh, yes. I think I really impressed them that I could answer those questions just by that. But it's because of the effect that their eating disorder is kind of taking on brain functions for things like mood and physiological functions like sleep. So when we talk about things like anorexia nervosa, we always say that the primary medication is vitamin F. It's your food. It's weight restoration. Weight restoration to me is again brain restoration, because if somebody restores 2 pounds on a scale, to me there's a certain percentage of that equivalates to hundreds of thousands, millions, and maybe multiple millions of brain cells, kind of connecting and communicating again where they haven't been. That can be both with the brain in a cognitive way, and it can be with the body in other ways as well, or helping the body regulate hormonal secretions that regulate your circadian rhythm so that sleep kind of gets back to normal again. So food kind of like is the main medication for anorexia nervosa. And so that vitamin F is actually the only thing. There are no medications for anorexia nervosa that are officially indicated by the FDA to treat the eating disorder. There are 2 medications that do have FDA indications for eating disorders. The first one came out in about 2015, and that's Vyvanse, lisdexamfetamine. Vyvanse was originally a medication that came out for people with ADHD, but has been found to be relatively efficacious for binge eating disorders, and at least about half the people who use it. I always find clinically, and this is my own personal experience with it, that people who respond best usually have kind of an ADHD or a disorganized type of personality and behavioral style. So I'll often ask them, like, what's the inside of your car looks like? How well is it organized? People who have a lot of organization sometimes won't respond as well as somebody who has more of a disorganized type of lifestyle or more of a ADHD type of thinking. You don't have to have ADHD for it to be effective, but it seemed to be more efficacious in those who have that type of thinking approach. The other medication is Prozac, or fluoxetine, and that came out in 1996 for bulimia nervosa. So that is an SSRI. Originally, came out for things like depression and anxiety, and it's used for other purposes as well. But it does have that official FDA indication for bulimia nervosa. Now, meds like Prozac and Vyvanse doesn't mean those are the only 2 that can help with conditions such as binge eating disorder or bulimia nervosa. It's just that these 2 meds went out on a limb to get a special indication officially from the FDA to say, well, we've shown and demonstrated that this is effective for these conditions. I do want to mention here that I am not recommending that you go to your doctor and say, oh, I heard this lecture, could you please give me Vyvanse, could you please give me Prozac? The decisions to use any types of meds is something that has to be taken seriously with a lot of different considerations related to an individual's medical status, psychological status, and other medications that one may be taking, both prescribed and over the counter. So again, through this whole series, but especially when I talk about some medications here, do not take this as medical advice and insist your doctor give you these types of medications. So like I said, Prozac or fluoxetine came out around 1996. And in this study, what it kind of showed was people who took Prozac, if they didn't get a 60% remission in their symptoms with bulimia nervosa by week 3, it often wasn't going to be effective in the long run. Now, that's an interesting study, and because they're kind of showing that the med may work in some. If it doesn't work by a certain time, it's probably not going to work. But that is not necessarily how physicians and clinicians should be making decisions based on studies like that. Because if somebody they didn't meet criteria of 60% remission, but they had a 50% remission with their symptoms of bulimia nervosa, trust me, that individual will be really thrilled with having that reduction of 50%. So it might be something that people still might consider continuing. Also, Prozac doesn't usually reach its full effect for up to 6 to 8 weeks. So when looking at certain types of studies, and I put this one up here, I don't have the title of it, but I do have the source cited. It's important to know how to interpret and how to maybe apply that to a treatment plan and one's clinical practice. Now, why would a medication such as a Vyvanse kind of work in people with binge eating disorder? Like I said, they kind of have that similar type of disorganized thought process. Well, there are common findings with eating disorders in this study here, like ADHD and binge eating, that there's similar circuitries that are firing off and look very similar in each condition. So kind of regulating one condition helps regulate the other, it appears. And this is from the neuroimaging research that's being done. So an individual with ADHD has a lot of stuff going on in the frontal lobes, where OCD, where focus, attention, and even the reward system is involved. And it is the same thing, again, with binge eating, as we've discussed on the episode in binge eating disorder. I've also spoken about that protein, that brain-derived neurotrophic factor, okay? And this was an interesting study. It looked at the medications called your SSRIs. And again, those tend to be a lot of your antidepressants and your anti-anxiety meds. Those are your fluoxetine, fluvoxetine, brand names such as Lexapro and Zoloft and other things as well are SSRIs. And what this showed in this study actually is the study looked at people who had low levels of BDNF, brain-derived neurotrophic factor. And with those low levels, there was high rates of major depressive disorder, suicide thoughts, and suicide attempts. When treated with the SSRIs, it increased the levels of the brain-derived neurotrophic factor, which led to a decrease in the suicidal thoughts and the suicide attempts. Now, it's a long talk here. A lot of meds, any med that will affect the central nervous system usually comes with a black box warning that it could increase suicidal thoughts in children and young adults. And this was because a lot of people who were being treated with medications that affect the central nervous system, including your antidepressants, people were started, and there were high rates of suicide. I usually talk to my patients about this. We monitor it closely. I always say a medication doesn't actually cause a type of thought, but it can not be enough at times. For instance, there's a lot of prescribing issues with medications like SSRIs. At one point, over 85% of these types of meds were not being prescribed by psychiatrists. They were being prescribed by other types of physicians. So medical follow-up and maybe proper diagnosis was always in question. Meds like this can also cause side effects, which might cause an internal agitation, which if you're already depressed, can make it so that you just can't take that physical feeling along with your depression. And early on, even with Prozac, sometimes when people are in such low levels of depression, there's not even an energy or a will to actually take steps to harm oneself. And when the depression starts to lift, they actually may then develop that energy first. The key point here is it's important that you talk with your physician, that one understands the risks, and that they're followed closely when they're on these medications, as opposed to, the practice that I think happened before that black box warning was somebody came in, said maybe they're depressed. They were giving some samples in the office and said, I'll see you in 3 months or I'll see you in 6 months, and there was never a close follow-up. So, hopefully you will always maintain an open dialogue with the person who's prescribing your meds, and they will follow you closely. I also talked about that, when someone is under stress and it's left unchecked, the body produces its own cortisol, which can be very neurotoxic as well. And there's been many studies that shows that, like I said, antidepressants have helped decrease cortisol levels. Antipsychotics, or what we call now neuroleptics these days, they decrease cortisol levels. Stimulants, in some studies, increase. Some studies, there's no change in cortisol levels. But what I'm saying is how meds work is not only how they affect the brain, the release of certain neurotransmitters, but it also helps control things like hormones and types of important proteins like brain-derived neurotropic factor that you find in the body that they make on their own. So without getting into specific medications, the types of meds that are often used with eating disorders include antidepressants, anti-anxieties meds, mood stabilizers for things like bipolar disorder, or sometimes even for like borderline personality disorder, ADHD meds, because sometimes you can have an eating disorder and yes, ADHD with it. Anti-seizure meds are not uncommon. They're sometimes used as mood stabilizers, and they're sometimes can be helpful with decreasing urges for binges, and sometimes also some people benefit with decreased internal thoughts related to the eating disorder or body image. Sleep medications are often something that is required. I always prefer to start off with over-the-counter medications, but I always say there's 3 factors in any individual's level of mental health that have to be relatively well. That is an individual's sleep, an individual's nutritional intake, and an individual's getting at least moderate activity. Anybody who doesn't have that in a balance, often they're thrown off both mentally and physically. So sleep medications, trying to help someone get some sleep, is usually involved, although I go back to it's usually related secondary to something going on with an eating disorder or disruptions in the circadian rhythms. People take meds for other related conditions and medical conditions. So, when one's on meds, you always want to check for interactions, and you want to check what effect it may have on appetite. As somebody who works in the field, I pretty much know my patients who fear weight gain are not going to take any meds I prescribe that cause weight gain. So I have to be cognizant of that and work around that. And the role of the meds are basically to first stabilize moods. It's hard to do therapy if you're very anxious or you're very depressed, okay? Although sometimes that anxiety and depression won't respond to meds because it's secondary to the eating disorder, and I always have to have that discussion with patients and families. Meds are used to treat diagnosis. If one has a diagnosis of ADHD or one has a diagnosis of bipolar disorder, that has to be controlled. They're used to manage distressing thoughts, the eating disorder thoughts. They're not perfect, but if I have an idea for something and someone says my head is just going nonstop and it's so distressing and it's making me want to self-harm, and I ask them if I can try something, maybe it's going to reduce your ed thoughts by 5%. Almost every patient will say, I'll take it. That's how distressing those thoughts are. But I'm usually shooting to just decreasing those distressing thoughts a little bit, closer to 20 to 40%. Won't make them go away, though. You use meds, like I said, to help with therapy when you treat the moods and everything. Not only does a person do better therapy, but it helps them remain compliant with therapy, to show up on time, to do the exercises that may be assigned to them. And by doing all of this, it's really healing the brain and the central nervous system. Meds are something you have to take very seriously. They can sometimes have serious side effects. Most of the time when it's done right, they're well tolerated. Sometimes they're short-term and used as a tool. Sometimes if it's something chronic, it might be prescribed for a longer period of time. But hopefully they're all being used to be neuroprotective, to heal the brain and the central nervous system. Now, I'm a psychiatrist, so of course I can prescribe medications, but I would love if instead most of the stuff I have to prescribe for, people would do things like mindfulness and meditation. And in a simple term, there's only one difference. That's that one letter there. In reality, however, we often live in a world where people say, it's a lot easier for me to swallow a pill once a day than it is for me to spend hours meditation. I don't have time for that in my life. And if I can take a medication and feel better in a couple weeks, or you're telling me I have to do meditation, daily for years, people tend to shy away of one of the best things they can do for themselves that'll cause significant changes in the brain, which we'll get to in the section on mindfulness and meditation. I always want to encourage patients to engage in mindfulness and meditation as a part of their lifestyle, not just as a short-term tool, but really make it something. I look at it as when someone does this, takes it seriously, and does this for years, their brain kind of evolves. And there's no other way you can do that. You can't do it with medications, and you're not going to do that just with talk therapy either. So it's an important part of all treatments. So again, thank you for tuning in. I will be speaking to you in our next section on NeuroSeries 11, the Neuroscience of Mindfulness and Thought Control.